So I'd like to make a start by welcoming everybody to our very first face-to-face event of Parliamentary Friends this year, and thank very much our co-conveners, Katrina Billick and Nola Marino, for continuing to be our co-conveners with the new group of Parliamentary Friends. We're really delighted that, in fact, we have the greatest number of Parliamentary Friends in the history of Parliamentary Friends of Palliative Care, which is fantastic. It shows the commitment and the dedication to palliative care. My name's Camilla Rowland, and I'm the CEO of Palliative Care Australia. And today I would like to acknowledge that we're meeting on the lands of the Ngunnawal people and pay my respects to their elders past and present, and also acknowledge we're on the lands of the Ngambri people and pay my respects to their elders past and present. And I'd like to welcome any Aboriginal and Torres Strait Islander people here today from whichever regions you come from. And thank you for your ongoing contribution. So today, we are going to have a focus on workforce. And I know that we have many people in this room that I'd like to acknowledge that are here to hear about the issues and the solutions that we have around workforce. So I'd like to thank the Palliative Care Australia board members, past and present. I note that we have Professor David Currow and Professor Patsy Yates, who are past board members of Palliative Care Australia and still highly involved and leaders in our sector. I'd also like to thank all the senators and representatives who are here today from the federal MPs and their advisors. We are delighted that you've been able to make it after a very big 2 weeks. I'd like to also acknowledge all our stakeholder organisations and our partner research and other national peak bodies that are here today as well. We've got a great turn up, so thank you. So let me provide you with some background. We know that in Australia, every year 100,000 people die from life-limiting illnesses. Of those 100,000, we know that 60,000 can access palliative care or do access palliative care. We would like to close that gap because we know that gap is only going to grow as we head towards 2050 and we double the number, according to AIHW and KPMG reports and Peacock reports. We know that number is going to double by 2050 to 200,000 people per year. We need to plan for the future, but we also need to plan for now because we've been through a period of COVID, as you all are very aware, and what we've heard from our clinical leaders is that not only has there been an increase in demand for palliative care of around 30% on average across Australia in the last 3 years, when that's mostly people with life-limiting illnesses who weren't diagnosed and treated during COVID lockdown periods. We know that that's going to continue as well as people's symptoms start to emerge. But we also know that we don't have sufficient palliative care workforce, both specialist palliative care workforce, as well as other health specialties who deliver palliative care, such as GPs and oncology and other areas of health. We know that we don't have sufficient workforce trained to meet the need. So we are calling for the development of a workforce strategy. And today we are focusing on what does that look like? What are the issues? What are the challenges? And you'll have noticed up the front, we have a couple of boards where people are already placing their comments and thoughts about what we need for the workforce strategy. So without further ado, I would like to introduce our two co-conveners. Firstly, I would like to introduce Senator Katrina Billick. Katrina was first elected as a Labor Senator for Tasmania in November 2007. Her advocacy for palliative care is personal, as someone who has had to respond to the challenges of brain cancer during the 14 years in Parliament. Please welcome co-convener of Parliamentary Friends of Palliative Care, Senator Katrina Billick.
Thanks, Camilla. Nola and I have not really chatted about how we're going to handle this, so I think Nola will do what I forget, which is possibly quite a bit. But as Camilla said, my involvement and links with palliative care are quite personal. In 2008, I was diagnosed with and operated on and had 2 brain tumours removed. I am living with 2 more, so just call me the brain tumour kid, you know, I don't mind. But in that time, I was put in a induced coma for 4 or 5 days, and then when they woke me up, they said to me, you have to have this surgery and you might die. Oh, thanks. Or you might end up in a vegetative state. Whichever case, you need to talk to your family and, you know, sort out your issues And I said, oh, how long have I got? And they said 24 hours. So I didn't actually even get to use palliative care in those days. But the thing I did learn was that palliative care is not just for people at end of life. It's for people with life-limiting illnesses. And it's not just about health. It's about those issues of emotional support and psychological support and cultural support and social support. And I think that's the message I try to send to my parliamentary colleagues. The great thing about the Parliamentary Friendship Group is, one is working with Nola. We do tag team really well, and we do firmly believe that although there's hundreds of parliamentary friendship groups now, it's just become ridiculous, quite frankly. Well, this is obviously the best one, obviously. But, you know, it is like, you know, it's nearly like, can we have a parliamentary friends of people who want to go shopping on Saturday morning type things? It has got a bit silly, and I think Nola agrees with that. And we've both been around here for a few years. I'm into my second decade, as someone reminded me the other day, which made me feel exceptionally old. Yeah, very rude of them, Nola. Anyway, but they're the things I try to get through. And of course, recently we've had, in my home state of Tasmania, we've had the voluntary assisted dying legislation finally go through, and we've got territory rights issues as well in the Senate. And it's like, I just do remind people that voluntary assisted dying and power care are not mutually exclusive either, and try to explain to them that. One of the things, but the good thing about the Parliamentary Friendship Group is that people come along, and we hope they learn something. That's it. We hope that these messages start to sink in and get through. And if it's not Nola nagging people, it's me nagging people outside of, you know, the forum. But that's a really important thing to do, because we really have to get those messages through. My dear old dad, who died in 2015, always said, and you know, I was brought up with this saying, no one gets out of life alive. And it's true. And you know, we prepare for birth, and we prepare for people to have these wonderful births, but we don't very well prepare people for death. And people are entitled to have some dignity and a decent death. So that's what keeps me really motivated with this fantastic group. Thanks to Camilla and the staff and everyone else for, you know, keeping us on our toes and keeping in contact with us. I'm just going to hand over to, you know, my colleague Nola now.
We're like a tag team, but I'm really pleased to hear, Camilla, that we've got so many parliamentarians who've signed up to be part of palliative care. I can see some of the, would you please put your hands up if you're a senator or an MP in the room? Right. So, you know, you should be really proud, palliative care, that we were able to get this many people who are MPs and senators. The Senate sat till 11, and people have made an effort to come here. We've got the House of Reps people as well. It's been a really pressured week for many. And the respect that you see for palliative care is such that those people have made an effort to come this morning. And I really wanted to thank them for that. But we want you, Katrina and I want you to learn so much more and carry the flame, because each of us as members of Parliament need to do that. One, to make it easier to talk about palliative care throughout the extent of a serious illness or one managing pain, but equally to say that my mum, like your dad, said to me, well, something's got to kill you. And she was pretty straightforward, being a rural and regional person. And so this workforce issue for me extends right. I'm a rural and regional MP and have seen a lot of the challenges in my previous role in the most remote parts of Australia as well, with palliative care, and the different needs that we have and how we supply workforce into that part of the world, or services, or the support and comfort that we need at that time of our life. And I think the one thing that Katrina and I agree with really strongly is how, you know, each one of us is going to get there. And so, you know, what do you want? How do you want it? Who do you want around you? What are the good plans that you need to put in place? And palliative care, great palliative care, you know, no one goes with us at the end. And so it's important that the process to get there is one that's guided by great palliative care. And our goal is to try to see that everywhere we can. And we really encourage all MPs to actually be part of this so they can assist their communities to do so. So thank you for coming. For those of you who've had a process to get through into this place at this early hour and you got up so early, thank you. And I'm really looking forward to the speakers.
Thank you, Noel and Katrina. And obviously they really do need no introduction because they're so passionate. I hear Katrina and Noel, or wherever they go, talking about palliative care, to the point where I was at an event at Dementia Australia yesterday and Noel was there talking about palliative care up on the stage, which was brilliant. And a colleague of mine was saying how Katrina is now involved in the National Redress Scheme, but was talking to her about palliative care as well. So you're fantastic advocates. So thank you to both of you. So to move on to our next section, we do have people live streaming today coming in online. So I'd like to welcome those people. And we will have time for questions at the end of our panel session, about 20 minutes for questions. So please think about what you'd like to ask. So I'd like to introduce Professor Meera Agar. Meera is our Chair of Palliative Care Australia and will be facilitating this session. Meera is the Professor of Palliative Medicine at the University of Technology, Sydney, and a practicing palliative care medicine physician in Southwest Sydney. And just this week, Meera was re-elected to her second term on the board of Palliative Care Australia and is held in very high esteem by our sector. I'd also forgot to thank some of the Palliative Care Australia members from our state and territory and National Professional Association affiliates are here today as well. And thank you for travelling to Australia. You are in Australia. Thank you for travelling to Canberra. This is my third morning in a row of being here in Parliament House at 7 o'clock in the morning. So I'd hand over to Meera now to facilitate this session.
Thank you, Camilla, and thank you, Katrina and Nola, for that warm welcome and the advocacy that you do. And it's a real pleasure to have travelled from Camaragal land to the land of the Ngunnawal people. And I also pay my respect to any Aboriginal and Torres Strait Islander people joining us today. So this is a really important topic. Palliative Care Australia now knows that the community know what palliative care is. They are beginning to really understand what good palliative care is, and they know that they need that earlier and when they have needs, which excellent palliative care can provide. Australia has world-leading palliative care services based on the best available evidence, but the challenge is we have a large gap in terms of both the numbers of people who are going to need that care and people within the Australian community who, for a number of reasons, can't receive that care either when they need it or where they need it. And that is really the fundamental premise of today's discussion, that we need to think about the workforce we need to achieve that, but also how we deploy that and make sure that everyone, regardless of where they live or where they're receiving care, can have access to that workforce in partnership with social care and in partnership with our community. So I think it's going to be a very exciting but forward-thinking discussion and really pave the way to some important discussions that we need to have to achieve that. And I think very much within the remit of Australian policy and the workforce that we do have, very achievable given the excellence in palliative care that we have to build on. So we have three speakers this morning, and it's my pleasure to introduce the first speaker. So each speaker is going to speak for about 10 minutes, and then we'll have a good 20 minutes for questions from the floor and a reflection and discussion. So it's a pleasure to announce our first speaker, which is Associate Professor Mark Bowie, who is the Deputy Director of the Centre for Palliative Care and the Director of Palliative Medicine at St Vincent's Hospital, and also holds an academic appointment at the University of Melbourne. Mark has had a very broad career working in a range of clinical settings, including in rural and remote and Indigenous healthcare. So brings a very broad and depth to his perspective, and we look forward to your thoughts on this topic, Mark.
Thank you, Mira, and thank you to the parliamentary friends and also for Palliative Care Australia for the invitation to be part of this meeting today. Just wanted to mention that indeed it is World AIDS Day today, and it's an important in the sense of not only thinking about the past and the notion of people dying in unpredictable and communicable disease environments, but I feel like my career has been bookended by two significant pandemics in a way, where communicable disease has really brought palliative care to the attention of many people that really wouldn't have thought about it. I just wanted to acknowledge that for today. This is an important discussion, as Mira has spoken about and others have. We never really know when we're going to connect to that part of our life where we have to think about, is death going to be a possibility, a probability, or an inevitability? And as Katrina has mentioned, she really didn't have much time in that moment to have a concertina of thinking about what this meant going under this particular surgery and what the consequence would be. And fortunately for Katrina and people around her, she's still with us here today. But I think it's important, we do know the evidence is absolutely in. The palliative care value adds in so many ways to the healthcare system. Not only does it, and that can be from any point in the disease trajectory. As people have mentioned, what was once the concept of dying as being palliative care, and people still hold that as a bit of a myth. Indeed, we find ourselves working with our colleagues in parallel pathways of bringing people through a system that is complex by nature, but can be navigated in the real reality of the moment. I speak to you today because I have not only been a person working in palliative care for over 33 years, but I've also been a carer. My previous life partner died after 20 years together. I've also been somebody who's looked after parents who have died and others. But I think we do find that the value where we find in palliative care sits not just with the value add to the patient and the patient experience, but the patient and their carers, the experience of the caregiver and the families, the ripple effect across, and it can be intergenerational. We still get people coming back to our palliative care service remembering 20 years ago that event, whether you looked after the grandmother, really did pivot them to think about a career which they would never have thought about, and things like that by the care experienced. But the healthcare worker, we all benefit from the healthcare environment where we see collaboration, we see cooperation, we see where effective care and being present and developing relationships with people can lead to much better outcomes for the person involved. And we also see the benefits for health services and for government and for others. Government does great jobs, particularly in the federal interface, of supporting the programs in many, many ways. And colleagues overseas are envious of those support mechanisms to build the knowledge network, to look at the structures of training and education, to look at the way in which we can collect data and support registries and things. But our health services themselves are able to assist in the sense of preventable admissions, a reduction in ED presentations and so forth. We are a powerhouse of value if you want to look at the equation that might make up that place. I just want to bring very briefly into the equation a patient, a real patient, a patient who we got to know quite well, who was with us in the disease trajectory for 4 years. So often we meet people at the very pointy end, but for this is a situation of modern palliative care where Don, and he was very happy for us to use him and use his name and talk about him. Unfortunately, he died after 4 years connected to palliative care in June this year. I will come back to him. At different stages in the illness trajectory, and we talk a lot about this, there are many transition points. And in the specialist environment where palliative care connects, I think most people would traditionally know that often that referral to palliative care often comes in a delayed response. Now, increasingly, we're finding we are connected and part of healthcare teams. We're integrated into the chronic illness environment in a hospital and outpatient environment. We can be connected to our cancer colleagues, increasingly our aged care colleagues, and particularly for the management of dementia. But what you find is there's a backbone of specialists who work in palliative care. Now, the focus often, when you look at data, is around the medicine and the nursing particularly. And unfortunately, the thread of allied health doesn't quite find its way into the collection to show and demonstrate the effectiveness of not only physios, OTs, but art therapists, pastoral care, as well as others who might connect in indirect and direct ways, such as our volunteers and our other sort of therapists like massage and art therapists. But I think the important thing, and particularly for someone like Don in this 4-year journey, was that it was the integrated chronic illness clinic that brought him to palliative care's attention. And it really was around showing that there is a collaboration and an ability to see that there's something more than just focus on poor respiratory function. There's a sort of social, there's a well-being part of the equation. And Don's had become a very passionate spokesperson for palliative care, because he recognised he had the whole mythology of your palliative care only comes at the end of life, but he learnt what we could value add, and that value add was moving and navigating through a system that is complex, that we needed to understand his needs at that time for him and his caregiver at that stage. What's important in the specialist environment, of course, is that we then see that transitioning to more involved and engaged environments of our outpatient environment for palliative care. But then that translates eventually, most probably, to that recognition that there is specialist community palliative care. And indeed, there are presentations to our palliative care units. The ICU lens of looking at the behaviours, the social issues, the physical and psychological and spiritual issues that focus and really make death and dying such a difficult space to be in for many people. What we need to understand, of course, is that we have a strong primary care community workforce. Not only when we think about primary care, we often think about the general practitioner, but there are many other people, such as the support workers and paramedics, who are increasingly part of this equation. It's important to understand this. NDIS, we find increasingly NDIS is connected to our patients who have been relatively well. Maybe their disabilities and things have been such a big part of their lives, but death and dying does come to people with disability, as we know. And supporting the care workers has been a new area that we've really had to focus on. But that backbone of the specialist is still there to support the generalist. Aged care, as we all know, has become an increasingly big focus, and certainly from governments, to make sure that we can shore up the workforce, but also shore up the skill base and the transitions of the complexities that ageing, and particularly moving into residential aged care and community for those that are obviously going through decline, and particularly dementia. What we've seen most probably at the moment as well in this space is the fact that many of our hospital-based programs are reaching out into the community, because we recognise complexity doesn't just end when you move from bed in the hospital to being bed back in your own home. What I wanted to raise from this, though, was that that it is these transition points that are so important. Often I see the balance between what is sort of has a federal responsibility and what has a state responsibility still brings issues to the fore, where siloing naturally occurs because there is a siloed process. How often do we find when we have an admitted patient going to the home, we find that the workforce can't then support the GP. The GP is excluded from that primary care while there's still an admitted patient in the community. So that these sort of anomalies in the system that really do prevent the sort of transitional stuff from occurring in a good and sound way. What I think is important, and people will know these diagrams, is that there is this ability to move through the system. We well recognise that the generalists, the community-based providers, the people that, as we're finding in aged care, there is education and training. I mean, we have developed such great resources in Australia, but it's actually those resources reaching the people that need to find the key to unlock their ability to understand that this is part of their skill set that they need to develop and evolve. And we're seeing that evolution in aged care. What's most very missing in this, though, is then that recognition when generalists need to connect to the specialists, and those relationships still come back to the relationships that matter. So the relationships that mattered to Tom, so Don, in this process, he connected to all these parts of the system. Not only did he have community-based My Aged Care as part of his, over the 4 years, he eventually connected to specialist community palliative care. But the relationships for him that were the most vital was to see his long-standing respiratory doctor, as well as continue to connect to the palliative care specialist who had seen him in that space. But he appreciated all the other interconnectors, but for him that was the important bit, because they were sort of a bit of a linchpin in the movement in the system. And indeed, the discussions around coming into a palliative care unit to give his wife respite from the illness and the constant anxiety and distress that he was experiencing was appropriate and important. And particularly over COVID, that was such a significant thing for him to sort of give up his independence at home to come in to spend time with us as we sort of fine-tune some of the things that we were looking after. What's important also is that not only are we looking on the needs of the people, but we really need to focus on the care and support. And this tension, it shouldn't be a tension between generalist and specialist, but we need to broaden our palette and understanding of what we consider specialists who work in palliative care. Often there's criticism that most of the doctors who work in palliative care sit in hospitals, but we don't all work in hospitals. We move across the system. I support our Hume colleagues up to the New South Wales border from Melbourne. I go up and do clinics and we do all sorts of things there. But we find that there's this sense that doctors and others, nursing as well, and I'm sure when you think of allied health who are connected to hospitals as well, is that they want what they want from the hospital is the access to the academic, to the research. They want to have access to student training and all those sorts of things. So it's not that we exclusively work in hospitals, even though the data suggests that. It's actually that we move across the system, but the systems of collecting data and workforce knowledge aren't necessarily evident. And particularly, I think, for our allied health colleagues, where they don't quite get a mention in the whole arena, and indeed the training programs around our allied health colleagues are also a little bit limited. But I think it's important that always, I think the absolute gem of palliative care is we always keep the patient or person and the caregiver at the heart of what we do. And that's very strong philosophy of where I've worked at St Vincent's for the last 16 years. But it is, and it's fascinating how you can navigate the problems in the system when you keep the patient and person at the heart of the program. The other part of the equation, of course, is then the capacity and capability building. We can't continue to do this without building and elevating. Very few jurisdictions in Australia have any sort of capacity or capability framing. I've heard words for 10 years from Victoria that this will be coming, but still we don't see activity in this space. We don't see something to guide organisations to aspire to and elevate. Also, we need the research, and we've got eminent people in the room today who absolutely have been core to that development of research and continuous improvement and the notion of education and training. We need to support our workforce. We need to make sure that they can access these elements, not just as an add-on, but as part of their continuous professional and also personal development and growth. The one thing that most probably is missing in this space, though, is that strategic oversight of trying to work in the system to continue to develop and evolve. And I know Palliative Care Australia is doing a huge amount of work in that, re-looking at how can we take a sort of national strategy, but how can we bring it down to that state level as well. So there's a not a uniformity, but there's a congruence of strategic working in this space, that we're not all doing things in little silos and pockets, but we're actually doing things together as a collective and having our approaches to both levels of government and so forth. So if I was to come back to Don and think about what would he be telling you today, what would he be telling you? I think he'd be pretty positive, because his experience really did see the full gamut of what modern palliative care is all about. But I think many people we know, people who've got vulnerabilities, disadvantage, remoteness, access is one thing, but what you access, the variability is huge. And we even see it within our own Metro Melbourne. We've got seven or eight palliative care services that are area dependent, but the variation of what you do if you're on one side of the street versus what you're on the other side of the street can be quite pronounced. And I get to understand this because we do after hours triage for all specialist palliative care services within our Metro Melbourne nearly. We've got one or two we don't, but we get to see the variation from what comes to that. My desk is next door to our after hours triage service. So I get to hear the stories and the problems and the inevitability of, if you're in this particular service, this is what's delivered. If you're in this service, it's quite different. So we need the capability, we need framing, we need the strategic framing to be able to understand how we can all elevate ourselves to this space. So if I was to think what Don might say in this space, I think he would say he fully understood that he had the very best. And I think he would say, let's elevate what we are already doing. But we can't elevate that if we don't integrate. And I think the integration, which I'm sure others have heard across health centres, services, is vitally important. That integration, break down the barriers, but the barriers are certainly there. People may not know that activity-based funding has been fantastic in many ways, but getting that where most of our work now is in consultation liaison type work for palliative care specialists in hospitals and outpatient environment, it still relies on historical funding or somebody knocking on the executive of the hospital's door very loudly. And in fact, COVID and so forth, and even assisted dying has really helped leverage us to a much more prominent space. But the integration still hasn't occurred. The barriers are re-exerting themselves. Think about the AIDS back in the 80s, and you think about COVID now. These are two pivotal moments where we could push ourselves forward. But I think the other thing that Don would ask for is amplify. Don't keep palliative care in the corridors of little media releases. It needs to be something, as I say to our staff, one day we're going to see a tram go down Burke Street with palliative care is great or something written on there, and a national sign from Palliative Care Australia or something. But I think we need to amplify and not be afraid to claim this is such an important part of healthcare and healthcare delivery. So thank you.
Thank you, Mark. I think that's given us a lot of food for thought and wonderful start to the session. And so it's my pleasure now to introduce Mr. Rob Hill, who is providing us a voice of lived experience as the Palliative Care Australia National Consumer and Carer Representative. And he brings experience in terms of the care of his parents, which I'm sure he will draw on and as he speaks to us. So thank you, Rob.
Thanks, Mira, and thanks to Camilla and the team at PCA for inviting me along today. I always enjoy the opportunity to come and share my experiences with people, and hopefully I can add a little bit sandwiched in between these two other wonderful speakers. So like Senator Billick, I'm a born and bred Tasmanian. So you were right, Camilla, I have travelled internationally to be here. I grew up in Launceston, which is in the north of the state, for those unfamiliar with Tasmania, home of Ariane Titmus and Ricky Ponting. I was going to drop a couple of AFL references in there, but then remembered we've got people from New South Wales and Queensland here, so I thought I probably shouldn't. So I just want to give a little bit of background to me to begin with. So I grew up in Launceston. I moved to Hobart for university after finishing school and met my wife there, and now have 2 young children. On screen, you can see a fairly fresh-faced young man, pre-COVID beard and the general sort of disheveledness that comes with having 2 young kids. Alongside my beautiful wife, Mary, and my mum, Sue, and my dad, Tim. In this photo, I'm 25 years old. I was working full-time, hadn't yet had kids, obviously, and had no responsibilities outside of making sure I remembered to bathe, to eat, dress myself, and turn up to work in the morning. So it was bliss. Within 4 years of this photo being taken, my parents had both died. So this next slide just shows the span of my experience with palliative care. So the top squiggly line up there has 4 key milestones charted on it. So the first point there is January 2014. So that was the date that my mum was diagnosed with advanced lung cancer. So obviously this was an incredibly seismic and significant event in my life and had a profound effect on me. But my father was still in reasonable health at that time, other than some ongoing sort of chronic conditions. But he was able to do a lot of the grunt work in taking care of my mum. So my life remained fairly stable for that period up until October of 2014, the second point along that top line, which is when my dad was diagnosed with terminal pancreatic cancer. His illness trajectory was fairly standard. I suppose you describe it as as much as an illness trajectory can be standard. Anyone who's had any experience with cancer knows that every person is unique, and every situation is completely different. But his treatments had little effect to begin with, some minor slowing of the illness progression, but not a lot more. He was in and out of hospital to get his pain levels manageable at home, and that's where he died in March of 2015, which is the third point along. So you can see a fairly steep decline after he was first diagnosed. The next point along that chart is April 2017. So that's when my mum died. But to be honest, I could put a lot of points in between March 2015 and April 2017. There was a lot that happened in that period. And I think this squiggly line, other than being one of the few options I had in PowerPoint when I was putting this together, I think it's a really good representation of what it's like to actually care for someone who has a life-limiting illness, because it does go up and down like that. So April 2017 was when my mum died. I've also listed my volunteer experience down the bottom. So I began volunteering in May 2018 after I'd had a little bit of space in between caring for my parents, and felt like I was in a good headspace to start volunteering. So I began volunteering for an organisation called Hospice Volunteers South, which manages palliative care volunteers in the south of the state. There are similar organisations in the northwest and the north of Tasmania. So I was based in what was called, it's now another impact of COVID, it's closed down. It was the Cancer Support Centre in the Royal Hobart Hospital. So I was based in there, but I would also visit palliative patients across various areas of the hospital. They were referred to us by the Tasmanian Health Service, and we'd go and spend time with them, provide some respite to family members who had been sitting there all day, and also just be another person for the patient to talk to. Unfortunately, I had to stop volunteering after about 12 months, my youngest daughter turned 1, and I just started working again full time, and I just unfortunately didn't have the time, but remained connected with the organisation as a board member until just a couple of weeks ago at the AGM, where I didn't opt for re-election. Just too many other things going on, unfortunately. But yeah, that was a really really great period of my life, and something I'm really proud of being able to give back. So I just wanted to outline some of my interactions with the health and palliative care system and workforce. So my mum and dad both had a number of different home care services provide service to them in their home. Those included nursing, general assistance, cleaning, allied health. But also after my dad died, my mum had some people come into the house and spend time with her overnight, just so that there was someone else there for company. So that was really, really great for me as her carer, because I was based in Hobart and she was based in Launceston, and it's about 2.5 hours, or probably longer now because they're doing lots of roadworks on the highway. Yeah, about 4. You're right, Senator. So it was a long trip in between, and so when I wasn't able to get up there and be with my mum, having someone there to look after her and make sure that she was okay, and just be a sense of companionship for her was really valuable. We also had a lot of interaction with specialist palliative care services, the multidisciplinary teams coordinated through the Tasmanian Health Service. These people were fantastic, always had positive experiences with those teams, but unfortunately they just weren't long enough. They're understaffed, they're overworked, and I would have loved to be able to spend a lot more time with those people when they were coming into the home or when my mum and dad went to see them. But unfortunately they just they didn't have capacity. But all of my experiences with specialist palliative care services were great, and I also had a lot of experience and interaction with them when I was volunteering at the hospital. We had obviously interactions with a number of clinicians. My parents' family GP was great the whole way through both mum and dad's illnesses, but he was only one person, unfortunately. I would have loved to clone him. Most of the specialists we saw were really good. Some of them I had some experiences with as a younger male carer. There were times when I felt like I was being, I suppose, talked around as opposed to spoken to. But largely, my experiences with clinicians were positive. Hospitals. My mum and dad both spent time in both public and private hospitals. Again, very overstretched and understaffed. That's a long-term issue in Tasmania's health system, which I'm sure a lot of people in this room will be aware of. And there's no partisanness or partisanity is probably a better term in that statement. I think that's been a long-term issue in Tasmania across multiple governments. So we won't get onto that because that's probably another series of forums, let alone one forum. But the staff in the hospitals were generally great to mum and dad, and also when I was volunteering, they were very good. Residential aged care, similar issues really to the others. I feel like there's a running theme here. My mum spent the last month or so of her life in a residential aged care facility, despite being only 62. It was really because of the lack of alternative options in Hobart that we had to do that. She moved down to Hobart for the last 12 months of her life, so that it was easier for her to be around family. And my son had just been born, and it was just a better fit for her. But just because of the lack of options, that's where she spent the last month of her life. The staff in there were really good, varying levels of, I suppose, speciality and comfort in palliative care and around dying people amongst residential aged care staff, which I think we might be going to talk about later on potentially. But yeah, again, great people. People who work in these areas are largely working there because they're passionate about what they do. They want to help people. They want to make a difference. And they're empathetic, kind and genuine. And that was certainly my experience as well. And then the palliative care unit in the north of the state. My mum was there for around about a week and a half, about 12 months before she died, actually. She had a UTI and then went into a sort of a delirium type thing for about 4 or 5 days. We saw a couple of palliative care specialists there, and they essentially told us to expect her to die in a few days' time, but she recovered somehow and lived for another 12 months beyond that. I have no idea how that happened, but yeah, again, they were great. And the volunteers in palliative care units, again, play such a vital role in providing that respite for the families and just being someone else to talk to. Often as a family member or a carer, there are conversations that you just can't have with healthcare staff. And having someone else to talk to is really valuable. And I certainly found that when I was volunteering, people share a lot of things with you that they probably wouldn't share with other people. And so there's just some general observations that I had about our experience. Again, as I said, the workforce in general, kind, caring and empathetic people. And experiences can have a lasting impact. And that's one of the things that's really stayed with me as I've had a bit of space in between my experience and been able to reflect on it. I remember an experience I had with a member of the specialist palliative care services team when my dad was dying. So she, for the last probably 2 or 3 weeks of his life, had been playing a really key role in helping to coordinate services and just keeping the family up to date with what was happening. My sister and I were based in Hobart, and obviously we weren't able to get up to Launceston every day. We were coming up every weekend, and I was doing a lot of midweek trips as well. And I'll use her name because she doesn't work there anymore, Caroline. She was great. She just kept us up to date on what was happening and just kept in regular contact. And my dad actually died on a Sunday morning. And so Caroline called me the Friday before in the morning, just to make sure that I was coming up that weekend. And I was actually already on the road, and I talked to her on the phone, and she said, "Oh, hi, Rob, just making sure you're on your way up." And I said, "Yeah, I know, I'm just in the car now." She said, "Have you got enough clothes and enough stuff to tide you over for a week or two?" And I had, because it was at that point, the last few weeks, where every weekend I was going up, I was preparing to be there for an extended period. And so I did. And she said she was really, really open, honest and empathetic. She said, "Oh, that's great, because I'm expecting your dad to die at some point over the weekend." And so she was just really honest and open and empathetic, and she delivered that. She didn't mince her words. She didn't use words like passing away, any of those other euphemisms that people use for death. She was just really, really straightforward and honest, but delivered that in a really kind and caring way. And then on the morning he died, so he was confined basically to a recliner in our living room for the last probably 4 or 5 days of his life, because he was non-responsive and unable to move, and it just would have been too traumatic to everyone involved to try and move him. So he was on a recliner in our living room, and I actually slept on the recliner next to him for the last 2 nights of his life, because I didn't want, if anything happened, I didn't want him to be by himself. And so the morning he died, I had a couple of hours sleep, and I was in need of a coffee. So my wife and I went down the road to get a coffee, and and Caroline called me when I was down there and said, "Hi, Rob, you need to get back here as soon as you can, because I think your dad is going to die very soon." So we hopped straight in the car. We drove home, got there in a couple of minutes, and were there with him and his brother and my mum and my sister for the last few minutes of his life. And it was just one of the most special experiences I've had in my life. And I can't thank Caroline enough for being there in the morning to start with. She turned up early in the morning to make sure that everything was okay. And just being kind and honest and caring. It was great. And those experiences stay with you for forever. So the next observation is just around the important role that volunteers play. I've talked about it a little bit, but you just feel such an important gap as a volunteer. Again, people share things with you that they just can't share with anything else, and patients will talk to you about things that they don't feel comfortable talking to their family members about. They might share their biggest fears with you, or they might just want to talk about sport or whatever it might be. They talk to you about things that they can't talk to anyone else about, and that provides, again, as I said, that respite to the families. We have a long way to go in talking about death, and it's a societal issue. And this has had, I think this has flow-on effects for the workforce, because workforce are members of society, and they have the same fears and the same reluctance in a way to talk about death as the general community. So I certainly saw some issues around that during my time. And the other one is that there are limited options for people, particularly in rural and regional areas of Australia. So obviously my experiences are based on someone who lives in Tasmania. I interacted with the system in Launceston, which is a city of 80 to 100,000 people, and Hobart, which is a city of 250,000 people and a capital city. So, you know, obviously not Melbourne and Sydney, but not small cities either. And as my dad's illness trajectory was fairly standard, we didn't really encounter too many issues in trying to get services and care for him. But Mum's was so much more complex for a variety of reasons. She had some existing mental health issues, which were compounded when the cancer spread to her brain and sort of manifested as like a dementia type illness. And we felt a lot of the time that her care needs were almost too much for a lot of service providers, and so we felt as though we were in the lurch a little bit. And reflecting on that, I don't think that was anything to do with the organisations and people that we encountered. I just think that the mix of expertise and the specificity of skills required to care for her just didn't exist where we were living, and it's an unfortunate reality. I've spoken to a few other people who've had similar experiences, and it seems to be a theme that if you follow a standard trajectory, the care's there for you, but sometimes if your needs are fairly complex, it's very tricky to find exactly what you need as a carer and a family member. That's why I'm so glad that we're talking about a national workforce strategy, and that's not just because in my day job I'm a bureaucrat and we love a good strategy or action plan. It's because I genuinely believe that greater coordination across jurisdictions will help a lot of those smaller areas, and help places like Tasmania that don't have the service options or the personnel to staff the service options that places like Melbourne and Sydney do. So that's the end of my talk. I just want to thank Camilla and the team at PCA again for giving me the opportunity. It can sometimes feel a bit self-indulgent to stand up here and talk about something that happened to you to a room of people that you don't know. So thanks to everyone for listening to me ramble on. Hopefully some of what I've shared today can inform future discussions around palliative care, and to help make it a good environment for people to work in, and for people to care for their loved ones in, and for people to die in and have their end of life experience in. So thanks for the opportunity, and enjoy the rest of your day.
Thank you, Rob. And I think a really poignant reminder that people who are interacting with the palliative care service are the people in our workforce. They're often caring for multiple people, and so the discussion today is much broader than health. It's about productivity and keeping our society and community working to its best capacity, and so really important issues that you've raised. It's my pleasure to introduce our last speaker, Professor Patricia Davidson. I think it's fair to say Patricia is a nurse first, and she also happens to be the Vice-Chancellor of the University of Wollongong, particularly brings experience in non-cancer care in the cardiovascular space, and very interested to hear your reflections, Patricia.
Thanks so much, Mira. My thanks also to PCA for inviting me to be here. My sincere thanks to Senator Billick and the Honourable Nola Marino for your leadership. And I think it's within the context of really political leadership and policy that I really want to draw on the really rich stories of Rob and Mark. To really kind of emphasise, I guess, how lucky we are in Australia in many ways, but also we're at a critical inflection point when everyone in healthcare is exhausted, but we really all need to step up to address this really critical challenge of the nursing workforce. And I think we can't deny where we are in the context of the pandemic. It's a critical inflection point in history. And I do want to sort of share some of my personal experiences of a different healthcare system and a different society. And I had the sort of honour and privilege of being the Dean of the Johns Hopkins School of Nursing for 8 years, and spent the first, nearly 2 years in the midst of the pandemic, in a situation where I never thought I would find myself. And I'm going to share some of these lessons because of the really, I think, important clinical leadership in Australia. And I think many of these people are here today, David Currow, Patsy Yates, Mira Agar, because of their clinical leadership and the solid bipartisan support of government. You know, Australia is really kind of the envy of the world in terms of palliative care services. And I was sharing this with Mark, who has a visiting fellow from the United States at the moment. So things that have just been such substantial reforms over the last 20 odd years, you know, PCOP, PACOP, interventions in residential aged care strategies to improve the healthcare workforce. I think they are so critically important. And it really underscores the importance of the government we have, the importance of democracy, and the importance of political leadership and strong policy. So as I mentioned, you know, I began the pandemic in the United States, and I remember it being very vividly being St. Patrick's Day. And any of you been in the United States, St. Patrick's Day is bigger than anywhere else, and in Baltimore it's big. And just this reality of what we were facing, and I had no idea that this would happen. I had no concept that I would have colleagues die. I had no concept that we would be there with literally no equipment. Can you imagine at Johns Hopkins Hospital, getting a paper bag with one mask, one shield, and told, look after it? So I think it really underscored to me the importance of health system strengthening, which I will talk to a little bit about. But I think we owe it to the many people who have died in this pandemic, including the most vulnerable, that we step up and we make sure that this never happens again. I think during the pandemic, we saw the most vulnerable suffer. I think we in Australia were well and truly on the road to recognising the vulnerability of people living in residential aged care. But, you know, in the United States, those issues were really pronounced. And I guess this to me was sort of, you know, a nadir of the pandemic. So at Hopkins, you know, very strong in global health. In my school, we had a program of Masters of Science in Nursing, Masters of Public Health. Many of those nurses went to work with Médecins Sans Frontières and all of doing this global health work. It was at that time I got a call from one of our new graduates who'd gone to work for Médecins Sans Frontières, and her deployment was to nursing homes in Detroit. that was how bad things were. And it's because of the lack of integrated healthcare systems, the absence of universal healthcare systems, the absence of government oversight. And I just think that remains with me the importance of good government, good policy, and integrated systems. And so reflecting over the pandemic, having been involved not just in the United States and really living through this period where we had colleagues die, but we did really well at Hopkins. But it wasn't because that was more an accident than planning. We did really well because we were a healthcare system. Now, those hospitals were acquired for financial reasons, not for public health or planning, but we were robust financially. We were able to cohort patients. We had a really committed healthcare workforce, and I really agree with the comments that I've made. People are drawn to these professions for wanting to do the right thing. All of the vaccination in Baltimore was given by volunteers. The chair of radiology, no one was too important. The Dean of Medicine, myself, was all due to being able to rally this volunteer workforce. It was coming back, and I came back to Australia in May 2021. And there are so many things about Australian society and Australian government that I think, today this parliamentary breakfast, which is bipartisan, that we should really celebrate. I got off at Sydney Airport, got on a bus, didn't know where I was going, with the Army and the Navy, and I felt entirely safe. So I guess I was really wanting to use my reflections of that system to underscore the importance of bipartisan leadership, the importance of good government, and how far we have really come in terms of palliative care in Australia, even though it seems that we still have a way to go. And the issue that we're critically facing at the moment is workforce. So I've also spent a lot of my career working in global health, and these are actually the 6 building blocks of a robust healthcare system. And these were actually developed by the World Health Organization, largely for low and middle income countries. But can I tell you, during the pandemic, these things just have been, this model has been validated. I think firstly, we can't deny the importance of leadership and governance. And, I really applaud, what has happened from the Department of Health and Ageing over different iterations of names and governments, but the importance of leadership, policy and financing. I think we really need to make sure that we have robust financing. We need access to good technology. We need data-driven solutions to palliative care, and Peacock has really set Australia up for great workforce planning. I was talking to Patsy this morning about, how now this data set is really coming to fruition to help with planning. And then, we can't deny the importance of the healthcare workforce. And we have many challenges here. We need a national conversation. We need all the players around the table, all the guilds, all the power groups. All of us as professions have to let go a little bit. Nurses have to let go a little bit of what we do to devolve some activities to other cadres of healthcare workers. Physicians have to delegate some activities to nurses. We need a national and global conversation. I think the intersection between palliative care and aged care is and people living with multimorbidity is critically important. And this is a conversation that we need to lead and not respond to. I'm just going to conclude by taking some of the lessons from the last pandemic. I really want to commend to you this book. It's called The Great Influenza by John Barry. And it really recounts the story of the past, that 1919 pandemic. In that book, the same issues, the absence of leadership, the absence of coordination. Again, this is very US based, but it really makes us really determined that we have to hang on to those systems of government that support coordination of care and support access to care for the most vulnerable. And of course, thank you. I am going to play the nursing card. Thank you, Mira. In that book, what is really interesting is that this book was written in 2005, but when he looked at what was going to help in the pandemic, he said that nursing could give the victim of the disease the best possible chance to survive. Nursing could save lives. And I just really want to draw that lesson from the pandemic to broadly palliative care, to take that beyond nurses to physicians, to allied health, or to whatever. One of the things that I've noticed, particularly in my experience of the pandemic, was, you know, a lot of the deaths really early we managed people much more aggressively. We intubated quickly, etc. But over time, it was more conservative management of symptom management, particularly breathlessness, that I think has led, as well as the, you know, antivirals and vaccinations, but to better treatment of patients. And I think, as you know, Mark illustrated with his patient that he cared for, this notion of multimorbidity, multiple chronic conditions, means that we all healthcare professionals need to not just be efficient in having conversations about treatment decisions, but we all need to really tune up our skills in symptom management. And then the last thing about workforce, I thought I would use an example of one of my amazing colleagues. You know, you work with these fearless nurses. So Nadia had been deployed in Bosnia, Syria. You know, when they come and say, is it okay if I go to Syria for a couple of months with MSF? I'm thinking, okay, just come back. But she went to New York in the pandemic in March when things were really bad. Lots of our staff went to New York to help out. And I said, came back and I said, how was it? She said, and these were her words to me. She said, you know, there was so much talk about equipment, about oxygen, about intensive care beds. And in the peak of the pandemic in New York, even at the best hospitals, the nurse to patient ratio was 4 to 6 to 1 in intensive care. And she said to me, you know, an intensive care bed without a nurse is just another place of suffering. And I think that really encapsulates, you know, so much of what palliative care brings to the healthcare intervention. And you can replace nurse for social worker or whatever. I mean, I just think in spite of, I'm a nurse now for 43 years, in spite of the amazing advances that we have had in my lifetime, you know, metastatic cancer is no longer a death sentence. People live from heart disease and stroke. But still, much of this increased longevity is with diminished quality of life and suffering. So I think that is our call to action. You know, I feel actually a little bit emotional, just say incredibly proud to be an Australian. I didn't know till I started to talk about it, just, you know, how impactful a time in my career it was. You know, how hard it was to see clinicians dying, and also to observe huge inequity in the healthcare workforce. In the United States, Filipino nurses are about 2% of the 3 million registered nurses in the US, but they were a third of the healthcare worker deaths in the United States. And that's not because of their training, but the vulnerability of settings in which they work. So I guess my final comment is we have a lot of work to do, but we have a lot to be very thankful for. We have a lot to thank decades of Australian governments who have chosen to focus on these critical areas as bipartisan issues. And thank you to the Parliamentary Roundtable, and keep your foot on that pedal, because we really need, at this critical point in history, to make sure that the serious lessons of the pandemic, the lives that have been lost, the suffering that's been incurred, is not for naught, and that we can move our healthcare system forward as a consequence. So thank you.
Thanks, Trish. And I think it's been at PCA, we've been very fortunate to work very closely with government through the COVID-19 pandemic working group, which I think speaks to several of the issues raised. Just really now, very happy to open the floor up for any questions that you may have of our panel members.
And just let us know your name and where you're working.
Aileen.
Thank you. Aileen Collier, and I'm here today for Palliative Care Nurses Australia. It's really for Patricia. Thank you for playing the nursing card. It's really important because we are the largest workforce. I guess my question is, we are still seeing new graduate nurses come out of their education not expecting to care for older people or people who are dying, and that they're going into an acute setting. And I just wonder, what can we do as a university sector to improve those nurses' expectations of who they're going to care for and what they're going to be doing when they come out into this array of clinical settings. And I just want to thank you, Patricia, for your insights and hugely moving as a nurse reflections, as well as to Rob and Mark. Thanks.
Thank you. Well, you know, I think part of it is, I think, advancing the science. If you look at the literature, you know, the most cited works are in critical care, etc. I think inspiring and motivating young people about the science in nursing school will change it. At Hopkins, which is, you know, ranked #1 in the country, people would complain, students would complain about having an ICU, placement. And the bottom line is, acute care now, except for exceptions of paediatrics, is about caring for the elderly. You know, can you believe it? You know, when I started working in cardiology, people debated whether if you were 60, you would get admitted to coronary care. Well, I'd be totally out. Now the average age in most cardiology units is, you know, 76, 78. So I think it's also changing about, you know, what healthcare is going to be. Hopefully there's going to be, if we can address health disparities, there'll be longer periods of good health in the earlier years, but, you know, acute care needs is often going to be in the elderly. But I think advancing the science, promoting nurses who are doing great work in aged care, I think it is really important. And the complexity clinically of palliative care. You know, I trained in critical care, but I can tell you that palliative care delivery is much more complex clinically than, you know, dealing with just one organ, one disease.
Can I just add something to that? I mean, I think taken from the sort of medical model, there's been a sort of 20-year systematic approach to reintegrating palliative care across the whole training trajectory, and things like, as people may know, in Australia we have palliative care curriculum for you, which again, Patsy is an integral part of that. There is a curriculum ready and available to go. It just needs leadership within universities to then reshape the way they look at this. And the poverty that you might find in nurses graduating, you'll find in many of the other allied health sector no connection to palliative or end-of-life care in their curriculum. So we do have leadership issues. And just to give you an indication, during the pandemic, so we were running postgraduate courses at the University of Melbourne. All those courses were axed as a consequence of COVID. So there's no longer a multidisciplinary postgraduate course at the University of Melbourne for specifically palliative care. So, yeah, leadership needs to come in all sorts of arenas, I think.
I think that's been a wonderful discussion today. I think the take home from me is that the connection between the stories, Rob's parents, the stories Trish shared, and the story that Don, though we may think that governance and policy is way over here and their stories are here, I think our speakers have really given us very clear threads in which everything that we do in all of our roles directly impact on those experiences. And I think, Rob, your words that experiences have a lasting impact, and I think that's just not about the personal experience. It's about how you continue to live your lives and the people who are left behind. So I think big impacts that we really all have a responsibility to be part of taking forward. And we have an excellent platform in Australia to do that. And the pathway forward is very positive, and I think we all have a great place to contribute to that. So I'm going to hand over to Camilla for some final words.
Thank you, Mira, and to our panel today. I think the panel's really illustrated some of the critical things we need to consider in relation to the palliative care sector going forward. And a number of our palliative care team at Palliative Care Australia, like myself, have worked in palliative care and all have lived experience. And having been connected in and out of palliative care for the last 30 years, I can still see that some of the issues present that we've experienced 30 years ago, and the nuancing now of what's required is really important in the development of a national palliative care strategy. On your chairs, you've actually had a handout which is about our May 2023 budget asks, and you'll see in there that we're asking the Commonwealth Government, the Australian Government, to invest in a workforce strategy because we feel it's critical now. Just to illustrate a couple of those points, just from a personal perspective, in the last 2 years, I've had 2 close family members die, and both experienced palliative care to a certain extent, one in a metro hospital where we had an amazing nurse practitioner develop a palliative care plan that was not followed at all by the care team in the medical ward. And so unfortunately, my mother-in-law died in a fair amount of pain and her symptoms not controlled. So after a disease trajectory of only 6 weeks from diagnosis to death. And also during COVID times in 2021, where we weren't only allowed to visit from family all across Australia, 1 member at a time, once a day. So these are sorts of things we're dealing with until this year. In an aged care facility, my father-in-law with dementia for 16 years, didn't have his symptoms recognised of a comorbidity, another disease. And it was not until we called a GP with a special interest in palliative care to go and visit in the last 2 weeks of his life that he received palliative care. And when he got it, it was awesome and he had a fantastic experience. But up until that point, the aged care facility, again, in a major metropolitan area, their staff were not trained in palliative care. They did not recognise his pain. They did not recognise his symptoms, and nothing was done until we called in a palliative care team. So there are many stories like mine and others. I just give this to you as a recent experience. It's September 2022, that today we still don't have aged care facilities trained in palliative care. Across, we have some great programs, and the department's doing an amazing job in trying to get some of those pilot programs embedded into the aged care sector, but we don't have it yet embedded. We don't have integration properly coordinated between specialist palliative care and general practice and other health specialties in practice. So we have these amazing resources out there that the department has put incredible time and effort and investment into projects, but let's make that bridge between these incredible resources and policy to actually occur in practice. So thank you very much for your insights today, because I think you've actually hit on all the issues that we have raised in our scoping of a palliative care workforce strategy, and we are hopeful that we can take this forward and obtain funds to invest in the workforce strategy. I just finally would like to say that we will have our annual report up on our website from our AGM this week. Please go to our website for all other policy and paper submissions that we've been putting in to the aged care reform, as well as other submissions that we've been working on. But I really liked when Mark said, elevate, integrate and amplify. That's really a great slogan behind what we're trying to seek in our workforce strategy. So thank you everybody for today, and thank you for your attendance. And I understand this is a very busy sitting week, so we've very much appreciated everybody coming along. Please stay in touch. Palliative Care is really keen, Palliative Care Australia is really keen to continue working with all our stakeholders and continue our great relationship with the Australian Department of Health and Aged Care, and of course with all the federal MPs. So thank you very much. Right, it's time for you to mingle up the back before we'll be asked to leave this space if you've got time to stay and chat.